Mr. Chairperson, distinguished speakers, professors, doctors, nurses, paramedics, ladies and gentlemen. I was given a topic by friends 2 weeks ago to talk about chemoradiation in cervical cancer. I'm probably not the best person to represent the oncology, but I'll do my best because of probably my limited experience compared to other oncologists. However, I've spent about 8 years in Australia dealing with this cancer. Okay, I also thank Prof. Nahazmi because making my talk easier, because he already touched a few of the topics already, and I hope you'll bear with me. Okay, chemoradiation in cervical cancer. As an introduction, cervical cancer is the second most common cancer among women worldwide. I take that from WHO, with almost 500,000 new cases each year, and almost 80% of women affected area in the developing world. Okay, if you look at the table, this is taken at 2002, that Southeast Asia is number 3 at that time, and at the West they're all decreasing. This because of the effective screening and prevention. Okay, just quickly, risk factors, if you all know for the last 2 days, is human papillomavirus, early age of onset coitus, large number of sexual partners, history of STDs, single risk factor of cervical cancer, high priority and long-term use of oral contraceptive. In pathology, investigation is around 9%, investigation around 10%, and the other rare cases, which is adenocarcinoma, small cell sarcoma, lymphoma, and metastasis. Clinical presentation mixed generally, 35 to 49%. 9 years, 60 to 69%. Here can be everybody here has a potential risk with cancer. 80% of women diagnosed with invasive squamous cell carcinoma screening. Pain and discomfort, pressure symptoms, vaginal passage of classification. We use FIGO classification, which is mostly used in clinical staging, often in a cervical worldwide. As part of the staging, FIGO staging is according to the clinical staging. To 4A is locally advanced, and FIGO stage 4B. Age and performance status, FIGO stage, T stage, volume, grade, and histological type, and information. If you look at the graph, basically the earlier stage have a better result, and the stage go up to 4B, then there will be poor survival. Okay, it's just a summary of treatment approach. One is the best. The best is when we talk together for every patient and make decisions together. But this is as a general rule. For one day, is good, in order of 95%, and either surgical or radiation with equal efficacy. However, surgical disease. Resulting in fewer longer-term bowel bladder and vaginal complications from radiotherapy, and allow for preservation of ovarian function if they are not working out. For stage 1 and 2, adjuvant therapy can be if, number one, if one high-risk features, which is positive margins, lymph node involvement, and microscopic parameter involvement. This is according to Peter's Journal of Clinical Oncology 2002, randomized 143 patients with stage 1, 1 or 2A, with one high-risk factor, radical hysterectomy, randomized to radiotherapy or chemoradiotherapy, which is cisplatin 5U, with a 2-cycle concurrent and 2 adjuvant. And it shows chemoradiotherapy is associated with better 4-year overall survival, 81 versus 71%, and progression-free survival. We also offer chemotherapy in features, the tumor is quite big, which is more than 4 centimeters, after trauma invasion more than 1/3, randomized to no further treatment or pelvic radiation, adjuvant therapy associated with 2 years 88%, and overall survival 85 versus 72% benefit. Okay, early stage cervical cancer for 1 and 2, definitive therapy can be but usually reserved for medically vulnerable patients or patients that refuse surgery. Meaning that surgeon said, "Makcik kena belah," then other treatment, which is radiotherapy. And HDR brachytherapy, high dose radiotherapy, 0.8 is likely to yield results similar to surgery. This is according to Jamal et al. With 5 years overall survival of 90% if you are negative and 40% if you are positive. Can be managed by radical hysterectomy, plus bilateral peripheral dissection, with or without post-operative radiotherapy, especially with the risk factor that I mentioned earlier. Or can be treated with radiotherapy, with or without concurrent chemotherapy. The landmark study that radiation oncologists study, which is published in Lancet 1997, radical surgery versus radiotherapy for stage 1B. In that study, 64% of surgery arm patients result for post-operative radiotherapy due to the risk factor above. The study showed equivalent 5-year disease-free survival and overall survival, which is 85 to 90% for small volume 1B and 75 to 80% for 2A. So either you have surgery or radiotherapy, and if you have surgery, you have risk factor, you have radiotherapy anyway. Or you just go with radiotherapy, the outcome is similar according to Ladani. The problem is the higher proportion in surgical group, not the problem, sorry, but the risk is that higher proportion of the surgical group have severe morbidity, especially with surgical and radiotherapy. It's about 28% versus 12% with p-value of 0.0004. However, adenocarcinoma suggests to have only subgroup that did better with surgery, and it also fit right with any adenocarcinoma, especially like even with colorectal, also do better with surgery. Another one is Cochrane meta-analysis, looking at 19 randomized control trial of stage 1B to 4A with definitive chemoradiotherapy, radiotherapy alone, and radiotherapy plus surgery. Compared to radiotherapy alone, chemoradiotherapy is a significant improvement in overall survival from 40 to 52% and progression-free survival. Significant reduction in both local and recurrence, suggesting that local control disease, suggesting that local control decrease is in failure. Figure stage 1B2 or 2A more than 4 cm, which carry 5 years overall survival of 80%. The option 1. Concurrent chemoradiotherapy, which is now considered as a standard, at least for radiation oncologists. Then we quoting the Ladani et al. Study, because our argument is bulky tumors more than 4 cm carry a higher mobility for primary resection. They also show the high rate of relapse after surgery alone, which is up to 30% in one of the series, and most patients require post-operative radiotherapy anyway, so the patient will have double whammy of the side effects. And the COP score more likely to be more than 120, with local organ relapse of more than 40, with tumor for more than 4 cm. The second option, which have been explained well by Prof. Azmi, is the role of neoadjuvant chemoradiotherapy and surgery, plus minus adjuvant radiotherapy, depending on the pathology. However, as Prof. Azmi said, conclusion is the neoadjuvant role is still inconclusive evidence, whether it's better than surgery, plus minus post-operative radiotherapy, or definitive chemoradiotherapy. Current meta-analysis failed to detect a significant benefit for neoadjuvant chemotherapy. There's one study currently occurring from EORTC 5594 comparing chemoradiotherapy versus neoadjuvant chemotherapy and surgery, and it's currently occurring. So we wait for that result so that we can discuss where to go from there. Okay. For advanced stage cervical cancer, figure stage 2B to 4A, which carry 5 years overall survival of 65%. For 2B, 40% for 3A or B, and 25% for 4A. According to American Clinical Oncology group published in Obstetrics and Gynecology 2002, all stage more than 2A are not considered operative candidate due to the risk factor I mentioned earlier, and should be treated with combined chemoradiotherapy. Surgery may reserve for relapse, but will ordinarily require pelvic penetration. Okay. Concurrent chemoradiotherapy versus radiotherapy alone have been discussed well by Prof. Azmi. The benefit concurrent chemoradiotherapy versus radiotherapy alone has been shown in 3 randomized trials. When I look at the Rostan book, actually now 5 randomized trials. It's from Whitney, Rose, and RTOG 0901, and the Cochrane meta-analysis. It's 4 reasons. There is one randomized trial, NCIC, that failed to show benefit. Others showed benefit overall. In addition, chemotherapy improved overall survival by 10%. However, if a patient not suitable for chemotherapy, for example, a patient with poor renal function, poor hearing, or elderly, or with multiple comorbidities, or patient do not want chemotherapy for any other reason, then it's not unreasonable to give radical radiotherapy alone. Quoting the NCIC study, perhaps show an optimal radiotherapy dose with optimal planning does not require chemotherapy. What about extended field radiotherapy? Extended field means when radiation oncologist treated paraaortic and pelvic, which is quite big field. For advanced stage of cervical cancer, without microscopic paraaortic lymph nodes. In RTOG 9001, the bulky 1B2 to 2A and 2B 4A, pelvic and paraaortic, which is extended field radiotherapy, versus chemoradiotherapy wins. So chemotherapy showed better overall survival and disease-free survival. So now oncologists did not change up to pelvic nodes, up to paraaortic lymph nodes, or locally advanced without microscopic paraaortic lymph nodes. If patient not suitable for chemotherapy, however, extended field radiotherapy should be considered. Taking from RTOG 7920, randomized controlled trial of 350 patients with 2B and no radiological evidence of paraaortic lymph nodes, randomized to pelvic radiotherapy alone and extended field radiotherapy. Extended field radiotherapy improved 10-year overall survival 44 to 55%, which is then 10% improvement roughly. But there is no difference in local control, 65%, or distant relay, 25%. The problem with that is toxicity was higher from 4% to 8%, that's from 100% increasing. Okay? For microscopic paraaortic disease, is potent and poor prognosis. If patient is still young and fit, you can consider staging lymphadenectomy and followed by definitive chemoradiotherapy. I'm not going to go into details about that. Okay, what about metastatic cervical cancer? Figure stage 4B. When in metastatic, it's considered palliation. When palliation, you have to look at the whole big picture, which is a general rule with the burden of disease outside pelvis and performance status. Then we decide on the treatment. Radiotherapy is a 2 symptomatic disease. For example, if you metastatic to the bone, you can give treatment for bone pain. And also for the pelvic disease, and we usually consider high-dose radiation to pelvis, as uncontrolled pelvic disease is very, very problematic. Pelvic chemotherapy with single-agent cisplatin or platinum-based doublet, as Prof. Azmi already described earlier, with topotecan, Taxol, or gemcitabine also can be given. I'm not going to go into details about chemotherapy. Okay, just a quick picture of USM. Alright, radiotherapy for cervical cancer. Now we begin. Just the last few slides just to show our machine. We've got external beam radiotherapy, which is on the right here, my right, your left, and brachytherapy, which is high-dose brachytherapy machine. Okay, external beam radiotherapy is radiation of photon beam generated by a machine called linear accelerator, which is LINAC, delivered to tumor from outside the body inside the tumor. Because of that, and because of the organ in the body or tumor move with respiration, bladder or bowel feeding, then we have to make a margin, or because we need to treat pelvic node as well. So surrounding normal tissue will be affected by radiotherapy, therefore they have side effects. Okay? And that's also the reason why there is a limit to how much we can give, how much radiation we can give. Usually to the pelvic area is 45 gray to 50.4 gray at 1.8 gray per fractions. This is a machine, the patient will be treated. This is, we're not treating pelvic on this one, otherwise it's the wrong area. Okay, for brachytherapy, brachy from Greek word means short distance, which is radioactive isotope or sealed source implanted or placed near or within the tumor volume. Radiation will be delivered from inside or within the tumor to outside. It's causing, we can give high dose to the tumor area or the area that we need to give and reduce the dose surrounding tissue because it drops rapidly. So it offers geometric advantage over external beam radiotherapy. So that's why together with external beam and brachytherapy we can give high dose to the area that we need to give. This is a machine, and this is one of the techniques that we use called tendon and ovoid. This is a tendon that we insert to the uterus and the ovoid on the side. Have to do it on the operating theater, on general anesthetic or spinal anesthetic. And calculation, one of the calculations using just the method of this one, point A and how much dose we can take. Okay? And brachytherapy also, put in here got a low dose rate and high dose rate. I just read up to date article 2 days ago. Low dose rate is still preferable for cervical cancer, but I don't think we have low dose rate. I don't have low dose rate in my center. I don't know any low dose rates now, almost gone. Chemotherapy, we all know chemotherapy is a drug that commonly we inject intravenously, as Prof. Azmi mentioned. For cervical cancer, we use platinum or 5-FU. In my center, we use platinum only. Okay, quickly, chemo-radiotherapy toxicity. Any treatment will have toxicity. For chemotherapy, nausea, vomiting, mucositis, myelosuppression associated with CTDP. For acute toxicity, and late toxicity for chemotherapy is ototoxicity, renal toxicity for cisplatin. If you add 5-FU, you need to check the heart as well. It can cause coronary spasm. For radiotherapy, diarrhea, proctitis, cystitis, dermatitis, which is intragluteal or perineal desquamation, vaginitis, nausea, lethargy, and chronic radiation toxicity. Leg toxicity is chronic proctitis, about 5%, cystitis, 5%, in 5 to 10 years. Vaginal stenosis, which is very, very important issue here. I always advise the patient on using vaginal dilator during radiotherapy and after radiotherapy, because it will be difficult for us as well as the gynecologist to follow up after, because the vaginal stenosis and we cannot even put scapula. So advise always on vaginal dilator, or the cheapest one is get help from the hospital. Radiation-induced menopause, which is if ovary treated, and second malignancy. Okay, last two, 3 slides. Role of anemia. I put that because it's quite important during the treatment of radiotherapy and chemotherapy. Anemia is common because of bleeding, nutrition, chronic disease, and treatment-related myelosuppression, especially with chemotherapy. In large Canadian series, 5-year survival rate differs significantly with the nadir of hemoglobin during treatment. More than 12, survival 74%, 11 to 12, 52, and less than 11, 45%. In Princess Margaret Hospital, randomized prospective trial to investigate the value of blood transfusion in anemic patients receiving radiotherapy. This trial suggested that those patients who were transfused had better local control rates than anemic patients, but the data was inconclusive. Some advocate with EPO to increase hemoglobin. Okay, lastly, role of optimal timing, which is also very important to us to ensure effectiveness of the treatment. In general rules, especially in textbook rules, radiotherapy should be completed within 56 days if possible. From the diagnosis, actually from the treatment, first radiation treatment, but far better if from the diagnosis to finish treatment, including brachytherapy for patients who receive chemoradiotherapy. A study by Luciano in Red Journal, 837 women underwent radiotherapy for stage 1 to 2 cervical cancer, looking at patients who received complete treatment within 6 weeks versus more than 10 weeks total treatment time. With more than 10 weeks, had significant higher rates of infield recurrence, 20 versus 4% respectively. So it's quite high infield recurrence from Luciano. And Perez, again in Red Journal, 95, 1,224 women with cervical cancer treated with effective radiotherapy for stage 1B3 disease. Women who were required over 9 weeks to complete treatment had significant high rate of pelvic failure and poorer disease-specific survival at 10 years compared to those treatment was admitted over a shorter time period. So that's why we like to encourage the earlier referral so that we can get down and treat the patient quickly. So, summary, cervical cancer can be totally eradicated as the topic of this symposium by effective extension program, effective screening program, cervical pap smear, and HPV DNA, effective management and referrals. Treatment choices are dependent on patient stage, performance status, and preference. Chemoradiotherapy plays a big role in treating cervical cancer, especially in locally advanced cases. Correct the anemia before treatment, which is preferable, and refer early to complete ultrasound within 56 days. This is recommendable. With that, I thank you.